Yes, sir. 3, 2, 1.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mat Singh Medical College, Jaipur. Today, again, we have a topic on female urology. This is overactive bladder. And this will be presented by our resident, Dr. Saurabh Garg, and would be moderated by our faculty, Dr. Dharmendra Jangir. So I would request Dr. Saurabh to kindly share his presentation.
Good morning, everyone. I'll be presenting class on overactive bladder. So, okay. The ICS definition of overactive bladder is urinary urgency, usually accompanied by frequency and nocturia, with or without urinary incontinence in the absence of infection or other obvious pathology. So, to diagnose a patient with overactive bladder, we need to check if there is any urinary infection or any pathologies there. We have to rule out that. Then we have to see urgency, frequency, and nocturia. Urgency being most important, and then it can be associated with or without urge urinary incontinence. So all components of OAB have been associated with diminished health-related quality of life, with the strongest negative association with urgency and incontinence. OAB can coexist with stress urinary incontinence or with mixed urinary incontinence. So overactive bladder is a clinical diagnosis. It is different from DO, detrusor overactivity, which is a urodynamic observation characterized by involuntary detrusor contractions during the filling phase, which may be spontaneous or provoked. So that's the difference between overactive bladder and detrusor overactivity. So, difference between OAB, that is overactive bladder, and BPS, bladder pain syndrome, is that the overactivity in detrusor is phasic in overactive bladder, that is in the upper graph. And in the bladder pain syndrome, it is a continuous rise in the bladder sensation or pain in the bladder pain syndrome. Now, differential diagnosis between overactive bladder and stress incontinence. So, if a patient has urgency, frequency, large voided volume, then he has urge incontinence, it is suggestive of overactive bladder. But if the patient has not much urgency, not much frequency, but mostly the patient complains of leaking of urine during coughing, sneezing, lifting weight, etc., small voided volume, then the patient is mostly of stress urinary incontinence. The prevalence is more in females and prevalence increases with the age. This is the diagram showing the nervous supply of the bladder, that there are two centers in pons, that is the storage center and the maturation center. Storage centers relaxes the detrusor and contracts the sphincter, whereas the maturation center contracts the detrusor and relaxes the sphincter. So it is the pathophysiology that normal filling requires parasympathetic inhibition and sympathetic stimulation to decrease the detrusor tone, and emptying requires just the opposite. So this is the diagram where we can see various receptors: muscarinic, nicotinic, alpha-1, alpha-2, and beta-3 adrenergic receptors. Those are on the bladder wall, bladder neck, and urethra also, to maintain this maturation reflex. Now, 4 hypotheses have been proposed for the pathophysiology of OAB. The neurogenic theory says that there is a reduction in the inhibition of the neural impulses and increase in the afferent impulses from the bladder that trigger this reflex. So there are more impulses, more afferent impulses from the bladder. The myogenic theory says that the detrusor muscle becomes more sensitive to cholinergic stimulation, leading to the increased spontaneous activity. Now, the autonomous bladder theory says alteration or exacerbation of phasic activity by the muscarinic stimulation. And the afferent signaling theory says that spontaneous bladder contractions during filling result in increased afferent output, hence the awareness of bladder filling by the patient. Now, etiology is mostly associated with aging. It is multifactorial. Now, bladder outlet obstruction is also contributory, mostly because it brings about some changes that are related to aging of the bladder only. Now, for assessment, we have to follow the AUA guidelines. We have to see history, physical examination, urine analysis, and then we have to go for advanced evaluation, that is UDS, cystoscopy, and USG. For initial assessment, we have to ask for loads, the volume of fluid intake, any neurological disease, any obsgyne, radiotherapy disease, or any medication taken by the patient, etc. And then we have to see the frequency volume chart, and we have to see the pattern of the voided volume. Then we have to do physical examination of abdomen, pelvis, extremities for any edema, any neurological problem. Then we have to do the assessment of bladder emptying. It can be performed by palpation as in clinic, but in clinic practice, it is more commonly performed with a bladder scanner. See, by that we can know the bladder volume. Now, there is a patient perception of intensity of urgency scale. So how patient reports it to you, he can say that I have no urgency, mild, moderate, severe urgency, or I have urge incontinence. Now, that is also depicted in this international consultation on incontinence questionnaire of bladder diary. So we have to ask that it has a scale of 0 to 3, in which it is said that if you have no sensation of needing to pass the urine, but pass urine for social reasons, then the scale is 0. If the patient has just normal desire to pass urine, scale is 1. If the patient had urgency, but this urgency passed before he had the time to visit the toilet, then it is scale 2. And if the patient has urgency and still remains in that urgency, and then but it did not leak urine, then it comes scale 3. So this is the international consultation on incontinence, a questionnaire of bladder diary. Now we have to do some lab investigations, urine analysis to rule out UTI, and we have to rule out hematuria, pyuria, we have to do culture, all these things. Then we have to do advanced evaluation, UDS, USG, cystoscopy. But these UDS and these things should not be involved in the initial workup of the uncomplicated case. It should be done as an advanced evaluation. The decision to pursue cystourethoscopy and imaging is based upon the presence of symptoms or urinalysis findings required in these studies. Now, very important part is urodynamic study that helps in the diagnosis of OAB. So urodynamics do not improve the outcomes for the cases, that is a patient with low PVR, no significant prolapse, no neurological disease, and minimal stress urinary incontinence. Guidelines recommend UDS testing only when urodynamic abnormalities will affect the decision to pursue or avoid an invasive or irreversible, potentially morbid treatment. UDS in OAB, we have to decide then whether antimuscarinics have to be continued. So we have to stop the oral tablets taken by the patient during this before this study, because otherwise the results of the study will be skewed. There are two main UDS findings in OAB, that is retrosal overactivity. It could be phasic or terminal, and it could be an early sense of filling. So it is in the diagram we can see, we have to see the P vesicle, P detrusor, and then we have to see the flow of urine, and then we have to see the electromyography. So in this, you can see in the second graph, in the blue line, this is a phasic rise in detrusor pressure. You can see. So a characteristic pattern seen in most idiopathic detrusor overactivity, that this characteristic waveform may or may not lead to incontinence, and it is characterized by contractions of increasing amplitude as the bladder volume increases. Now, the second is terminal detrusor overactivity, which has a single involuntary detrusor contraction occurring at the cystometric capacity, which causes incontinence, often resulting in the complete emptying of bladder. Now, then we can have exaggerated or early filling sensation in the UDS. Now, there is a classification of OAB based on UDS. It is based on the presence of DO, detrusor activity, patient awareness, and the ability to abort. 4 types are there. In this first type, patient is having symptoms, but no involuntary detrusor contractions are demonstrated on the UDS. So we can see in the P vesicle, there are some contractions, but the flow is not there. In the second type, there are involuntary detrusor contractions, but the patient is aware of them and can voluntarily contract the sphincter and prevent the incontinence and abort the detrusor contraction. So there are contractions, but the patient can voluntarily contract the sphincter and the flow is not there. The patient here prevents the incontinence from happening. Now, third type is, there are involuntary contractions, the patient is aware of them and he can contract the sphincter momentarily, but at the end, patient is unable to control it and the incontinence occurs. And the fourth type, there are contractions the patient is not able to contract and simply voids involuntarily. Management of overactive bladder. So first, there are 4 lines of treatment. In the first line, we do the behavioral therapies such as the bladder training, bladder control strategies, pelvic floor muscle exercises. Then we have advised weight loss, fluid restrictions, caffeine restriction. Behavioral therapy such as pelvic floor muscle training and the bladder training can significantly improve urinary urgency and urge incontinence episodes. Now comes the second line therapy, that is antimuscarinic agents, beta-3 agonist. So, antimuscarinic medications, all 5 receptors are found in the bladder, which type 2, that is M2 being most common, whereas M3 muscarinic receptors mediate the contraction of the bladder smooth muscle. However, M3 receptors also control contraction of smooth muscle in the GI tract, saliva, and iris sphincter. So, it will lead to some side effects such as constipation, dry mouth, dry eyes, etc. Absolute contraindications are if already patient is retention or gastric retention, then we avoid antimuscarinics. Now, the extended release formulations are also available in the market, and they should be preferentially used over the short-acting formulations because of low rates of dry mouth. Now, oxybutadiene is also available in the transdermal setting. Patches are available of oxybutadiene, and they have the lowest incidence of dry mouth. Tolterodine, this is a drug which in T-half of blocks 2 to 3 hours, appears to carry less risk of constipation. And derifenacin has the lowest serious side effects. And oxybutadiene has more memory impairment. Now, beta-3 agonist. Beta-1 to 3 receptors are located in the bladder detrusor muscle and urothelium, with beta-3 is being the main most common subtype. So, beta-3 agonist increase bladder capacity without altering the micturition pressure or residual volume. So, that is mirabackground that we use. Mirabackground was the first beta agonist, and it was commercially used since 2012. It has 150-fold higher affinity for beta-3 than beta-1. We have to cautionally use in hepatic impairment and end-stage renal disease. So this is the level of evidence and the grades of recommendation of various antimuscarinics, beta agonists, etc. We can also use the combination therapies, that is both the antimuscarinic and the beta agonist we can use simultaneously in combination. There are various landmark trials of these things: Synergy 2, Beside, and Symphony trial. Synergy trial suggests that if we want to check the patient reported outcomes of monotherapy of sulfenacin versus the combination of sulfenacin plus mirabackground, then definitely this combination therapy has better patient related outcomes. Now, Synergy 2 trial also suggests that if we use the monotherapy versus the polytherapy of sulfenacin plus mirabackground tablets, then the safety is also and tolerance is also good in the combination trial. So there is no problem regarding efficacy or tolerance. Beside trials also suggest the same, that we evaluate the efficacy, safety, and tolerability of these combinations versus the patient who have already remained incontinent after taking 4 weeks of monotherapy. Then also results are better. Now comes the Symphony trial. Here we evaluate the efficacy of combinations in various dosages, like dosage for sulfenacin 2.5, 5, 10, different dosage of sulfenacin with combination of different dosages of mirabackground also, and in these also significant improvement over monotherapy is noted. So it is all to say that combination therapies of antimuscarinics and beta agonists is far better than any monotherapy. So after the second line of treatment, we get third line of treatment, that is intravesical botulinum toxin injection or sacral nerve stimulation, tibial nerve stimulation. So, for patients with urge urinary incontinence refractory to antimuscarinic therapy, then both AUA and EUA suggest that we can use botulinum toxin A. Then FDA has approved dose of 100 units of botulinum neurotoxin A for idiopathic retrusor overactivity and 200 units for neurogenic retrusor overactivity. Then it is made in this way that we have to take 1 ml injections, each ml containing 10 units, and we have to inject it at around 20 sites with sparing the dry one. So this is how it's used. We'll see a video how it is used. Then its effects last at least for 24 weeks, or it will last even up to 6 months. Botulinum toxin injection for OAB has reduced the urine frequency by 29%, urgency by 38%, and daily incontinence episode by 59%. So it's a good therapy. But there are some risk factors. The primary risk of botulinum injection includes symptomatic UTI in approximately 20% patients, and the patient may need to have intermittent catheterization in 0 to 12% in trials, which is more in the real world studies. So this is, we can see the diagram of a bladder and the needle that is injecting 1 ml of injection, and we can see the blab that is being raised due to injection. There should be a good blab to check that whether you have put it in the right space. If there is a small blister or no blab is there, then it means that we have not injected in the right place. So Williams flexible cystoscopy injection needle is used, 23 gauge needle is. This is how we put it in the bladder, and the different spots in the figure B demonstrate the various points where we are putting it. The same diagram depicting the ureteric orifices and the points where we need to inject it. We inject it into the suburothelial layer, and a typical bleb occurs as shown in the diagram. There is a small video in which we can see the bladder, that is the right ureteric orifice, left ureteric orifice, and then there's a needle, and we are injecting the Botox injection, and the bleb is being raised, as we can see in the diagram. So 1 ml injections, each ml containing 10 units of Botox, and approximately 20 sites are picked up. Now comes the sacral neuromodulation, SNM. So this is also a third line treatment, as sacral neuromodulation blocks the C fiber activity, inhibiting irregular voiding responses. So refractory overactive bladder treated with sacral neuromodulation shows significant activation of the Brodmann's area 9 and left dorsolateral prefrontal cortex after SNM treatment. SNM inhibits bladder efferent pathways by stimulating the efferent portion of the pudendal nerve. So this is very important. How it works? It works by inhibiting the efferent pathways from the bladder via the pudendal nerve. So it blocks the more efferent pathways from the bladder. Now, it has got two stages, in which in the stage 1, we do a clinical trial of temporary or permanent lead placement for the external stimulation. So in stage 1, we just do a trial in which lead is placed and the stimulus is given and the effect is noted. Now, if it's a good effect, then we proceed to stage 2, that is implantation of a subcutaneous implantable generator. So sacral neuromodulation has been associated with a good 5-year success rate of approximately 70%, with mean reduction daily urgency incontinence episodes of 2 plus minus 2.2. And also, but it has a drawback that it includes a revision rate that is more than 30% patients need a revision rate. And furthermore, if we wish to maintain efficacy, we will require the revision of the battery. The battery needs to be replaced. So this is the pathophysiology. In the you can see the reflex in which the pudendal efferent is coming from the bladder neck, and the sacral neuromodulation is interrupting this pudendal efferent and hence closing the bladder neck. So this is the diagrammatic representation where the implantable device is placed in the left upper buttock. We can see the subcutaneous device is placed, and the lead is going from there towards the third sacral or neural foramina, and just at the near the pudendal nerve. So this a lead is placed under the skin 9 centimeter above the coccyx and 1 to 2 centimeter lateral to the midline, and lead is connected to an external device. That is how it is done, and we'll also see a video about it. Now comes the stage 2, in which the we do it as a daycare procedure. Stimulator is usually placed in the upper buttock. Medtronics is the company, and InterStim system is its patent device which is being used. The entire InterStim system will reside under the skin, and entire procedure takes less than 1 hour. Now this is the video showing. So these are the sacral nerves we can see, and this is the neurostimulator device of Medtronic InterStim. And from the third, this is the pudendal nerve going, and the device is placed just near it, and it stimulates it. So this is the how the action potential works in the nerves, and then finally what it does is it stops the excess of efferent impulses from the bladder that were resulting in the overactivity of detrusor earlier, and then it blocks the involuntary voiding that the patient was having. So this is how the efferent impulses are blocked, and the voluntary voiding is not blocked. So it has good results. Then comes the tibial nerve stimulation. Uh, it is a form of neuromodulation, same as sacral nerve stimulation. It targets the tibial nerve. The needle is connected to low voltage stimulator, cephalad to the medial malleolus into the foot to gently stimulate the tibial nerve. A portion of electrical stimulation reaches the sacral nerves. Treatment sessions last for 30 minutes weekly. So it has got multiple sessions. Patient commit to full initial 12 weekly treatment regimen, at which point the clinical results are evaluated. So the tibial nerve stimulation provides a carryover effect of the continued symptom improvement, even when the nerve is not actively stimulated, and it is also minimally invasive. But the limitation of this procedure is that has a need for the patient to be present in the clinical office to receive therapy, and the need to commit to a full 12-week therapeutic trial. So it has also got good results of 60 to 80% patients having good clinical response. And the burden associated with this that the patient has to come multiple times to 12-week cycle. Then comes the fourth line therapy. So after behavioral therapy, after pharmaceutical agents like beta agonist, antimuscarinics, then after sacral nerve modulation, and then Botox injection, then comes the fourth line therapy. When nothing works, then we may have to consider augmentation cystoplasty or urinary divergence in rare circumstances. The impact of OAB on quality of life must be weighted against the short and long-term risk associated with major surgeries and those alternative options, including containment or indwelling catheters. Thank you. Stop share.
Thank you, Saurabh. Mr. Nimesh, do we have experts with us? We may have Dr. Sanjay Sinha, Dr. Anita Patel with us. So do you find them?
No, sir, no.
No, okay, fine. So if they come, please let me know, right?
Yes, sir.
Okay. So Dr. Saurabh presented well, and he gave those videos also of Botox and SNM. I will try to briefly summarize the whole thing. In the meantime, if you have any query or any comment to make, all residents, faculty members, and those who might have joined us today can put it in the chat box or put your thumbs up sign so that we can take your comment. So we all know overactive bladder is a kind of a syndrome. It's a symptom complex, like bladder pain syndrome, right? So the chief symptom is urgency. So the urgency has to be associated with or without urgency incontinence, frequency, nocturia, right? And we have to, when we diagnose this syndrome or the overactive bladder symptom complex, then we need to rule out the basic pathologies like urinary tract infection, bladder pain syndrome, and other possibilities which can mimic such storage symptoms. So once we have ruled out this, then we can diagnose this as a case of overactive bladder. We all know that around 65% of women do develop an episode of urinary incontinence during their reproductive life. And the prevalence of overactive bladder in one of the studies has been around 16.5% in women, right? There are various risk factors, as Saurabh said. Some more are like if the patient has a family history of overactive bladder, then also there's more chance of developing overactive bladder. Then the parity is important. And then the age, obesity, chronic smoking, all these are risk factors for overactive bladder. When we talk about pathophysiology of overactive bladder, as I said, one is the neurogenic, where there's inhibition of the inhibitory pathways which prevent this contractions or prevent this detrusor overactivity. Secondly, it could be myogenic, right? And third, it could be due to the afferent signaling pathway. And fourth is the autonomous bladder. And more recently, it has been seen that there's a condition called dysbiotic urinary microbiome. So if the urinary microbiome gets dysbiotic, there are various studies which have shown that these can result in overactive bladder, similar to what it can develop into bladder pain syndrome also. So this is about the pathophysiology. Once we start evaluating a case of overactive bladder, we must do a urine routine, urine culture to rule out urinary tract infection. We must find out if there are other pathologies like diabetes or some chronic kidney disease and all these things that need to be ruled out. We need to take a proper history of these patients so that we rule out other pathologies like neurogenic causes, spinal lesions, and CNS problems like Parkinson's and other diseases, which may also produce such storage symptoms. So when you do on physical examination, yes, you do a proper physical examination just to see if the bladder is full or not, so that the patient may have overflow incontinence sometimes. You need to find out the pelvic examination need to be done. Proper rectal examination in males need to be done to and do a focused neurological examination in these patients. So once you have done all that, then we come to the investigations, as I said, a urine examination, which is most important. And then we may do some if there are some voiding symptoms associated, we do a ultrasound to know the post-void residual urine, uroflowmetry study. And if necessary, we will do a urodynamic study in these patients. In complex cases, in equivocal cases of overactive bladder, mixed symptoms, all these, we need to do a urodynamic study. So when we talk about the management of overactive bladder, so the first therapy is the conservative management, where we go with the lifestyle changes, right? Stop smoking, reduce weight, right? And then dietary changes, avoid kind of caffeinated beverages or carbonated beverages, and fluid kind of management. We need to take fluid at regular intervals in small volumes, not in large volumes at a single go. So that can produce these urgency symptoms. And similarly, we have to avoid spicy food and all those things to avoid constipation. Constipation is again an aggravating factor in these patients. So all these lifestyle changes are very important. Second is the behavioral therapy, where we the pelvic floor exercises. If the patient can actually isolate the muscles and properly do the pelvic floor exercises, he is properly counseled to do them. And it is usually patient is asked to do 10 to 15 minutes 3 times a day for at least 3 to 4 months. And the results will appear after maybe 4 to 6 weeks. And if the patient is not able to isolate, then we have to do a supervised pelvic floor exercises, where we either by biofeedback mechanism or by some weighted vaginal cones, we actually teach them how to do these pelvic floor exercises. And then comes bladder training. Bladder training is very important in overactive bladder. So how to distract or how to abort that kind of urgency, which leads to urge incontinence or sometimes frequency. So we have various techniques like distraction techniques, where you actually distract your mind from that urge. You try to do some kind of a back calculation, or you start counting from back for 99, 98, 97, 96, so that you just distract your mind from that urgency symptom, right? Similarly, you can take deep breathing when this is there. Sometimes you have to do some pelvic contraction to avoid this urge incontinence. That is called quick flick. That is, you just ask. These usually happen when there's a change in position. If the patient is standing from sitting position, there might be urge incontinence. So while changing this position, the patient is advised to contract her pelvic floor muscles, that's at least once, so that she doesn't have incontinence episode at that time. So behavioral therapy in the form of bladder training, that's a timed voiding where you ask the patient to slowly increase the interval between two voids. So you start with 10 minutes, 15 minutes, and then 30 minutes, so that at the end you reach a time when she can have that interval of 2 to 3 hours between two voids. So this is where you do a bladder training. And then if this therapy doesn't help, then we add pharmacotherapy in the form of beta-3 agonists and antimuscarinics. So because beta-3 agonists have less side effects, so we start with beta-3 agonists, and if necessary, we will combine it with antimuscarinics. We must know the various side effects of the various antimuscarinics. We know one of the important side effects beside constipation, blurred vision, and dry mouth, etc. of antimuscarinics, one of the important thing is developing dementia. Particularly when these patients are old age patients, they tend to develop dementia if you use a lot of antimuscarinics. So the best probably antimuscarinics would be either derifenacin or trospium hydrochloride, which doesn't cross the blood-brain barrier. So it is important to understand the various side effects of antimuscarinics. So if you, both of these are not then you may combine with different doses of antimuscarinics and beta-3 agonists. And if that doesn't help, then probably we have a case of refractory overactive bladder. Once this patient is refractory to all the pharmacotherapy and conservative therapies, then we need to go and see whether we need to put this patient for Botox injection or for neuromodulation. So neuromodulation, as I said, it could be PTNS, it could be TTNS. So PTNS is percutaneous tibial nerve stimulation, right? Where you put a needle in the tibial nerve. And TTNS is transcutaneous tibial nerve stimulation, where you just have electrodes or pads put on the medial aspect of the malleolus over the tibial nerve. And now we have TTNS in the form of wearable devices also. We have implantable device also available. So these are less invasive than the more invasive form of SNM, which is a sacral neuromodulation, as he had described. So if the patient is responding to PTNS or TTNS, then we might proceed to do a SNM in these patients to help them. And then then we need to, if the patient is not responding, is almost like a very refractory case and resistant case of end-stage renal disease, because this overactive bladder, though it's not a very serious pathology, it's not a fatal disease, but it has a very, very poor quality of life in these patients because the patient cannot go out. They do not have their own social activities. They cannot do their normal work, right? Because they have to find a toilet just a few minutes later, or sometimes because of the increased frequency and urgency. And they cannot even sleep at night. They cannot have their sexual activity at night. So the quality of life in these patients are very poor, and we need to actually take care of these patients very effectively. And so lastly, we have to resort to surgical therapies in the form of either augmentation, cystoblasty, or urinary diversion in very, very resistant cases. Talking about the future in overactive bladder and other therapies, we have newer drugs coming in. Particularly, there is a drug called nerve growth factor inhibitors. Then we have neurokinin receptor inhibitors, which are the new drugs. Then we have gene therapy also coming in. We have stem cell therapy coming in for overactive bladder. And then some therapies related to how to maintain the urinary microbiome to prevent overactive bladder. So these are some new therapies which are at present experimental. So this was in brief. If we have any expert with us, Nimeshi, do we have Dr. Anita Patel or Dr. Sanjay Sinha with us, or Pawan? Dr. Pawan, who is this PK? PK is okay. So I would request any of the experts, if you have joined us, please unmute yourself. Otherwise, I would request other residents, do you have any queries before we take up the MCQs? Yes, go ahead.
So how much time we should wait on pharmacotherapy to label it as refractory OAB and proceed for ADNS or ADNS?
Right. So good question. If the patient, usually 3 to 4 months of pharmacotherapy is important before we label them as a refractory overactive bladder. So if they are responding, so there may be partial responders, there may be complete responders, there may be totally non-responders to pharmacotherapy. We have to actually titrate the dose, try different combinations of therapies and different doses before we label them as refractory overactive, right?
So role of antibiotics, if patient has latent infections, chronic infections, then should we continue with the antibiotics?
So that's why it is important to rule out urinary tract infection before we label them as overactive bladder. So if it is a case of recurrent urinary tract infection, we need to treat them as a case of recurrent urinary tract infection, right? Any question? Right. So we will take up the MCQs now. Yes. This one. Here. Yes. So can we go? Can we just move back? Okay. So we'll take up a few MCQs on overactive bladder. Which definition or definition appear in the current International Continence Society terminology? Detrusor hyperreflexia, overactive bladder, idiopathic detrusor overactivity, detrusor instability, B and C. So this is the definition of overactive bladder, you would say? Oh, okay. So I think this is overactive bladder and idiopathic detrusor overactivity. Okay, both. So detrusor hyperreflexia has been replaced by neurogenic detrusor overactivity. The concept of tone is poorly understood, hence the term detrusor instability is not recommended. All right. Which symptoms are included in overactive bladder syndrome? Dysuria, straining, urgency, incontinence, bladder pain, stress, incontinence. So when we talk about overactive bladder, just think that urgency is the chief symptom, right? It's not urge incontinence. Urgency is the chief symptom, which may or may not be associated with urgency incontinence, nocturia, and frequency. So when it is a urge incontinence, then it becomes a wet OAB. So there are two types of OAB. It's a dry OAB and a wet OAB. So dry OAB has only urgency, and wet OAB has urgency associated with urge incontinence. Which features are characteristics of urgency? A normal sensation, it builds up slowly, it is usually felt suprapubically, it develops quickly and may lead to incontinence, A and B. D. So it develops quickly and may lead to incontinence, right? Right? Okay. Which statements are true for detrusor overactivity? It is characterized by phasic involuntary detrusor contractions during bladder filling. It is always accompanied by a feeling of urgency. It is a urodynamic diagnosis. It is a feature of the voiding phase of micturition, A and C. A and C. Detrusor overactivity can be diagnosed only if involuntary filling phase contractions are greater than 15 centimeters of water. If an involuntary contraction is seen during bladder filling, irrespective of size, if there is urgency incontinence but no contraction, if leakage occurs during exercise before urodynamics, if the patient has overactive bladder syndrome. A. Okay. So usually it is 10 to 15 centimeters. It may be, some people say to more than 10 centimeters. Okay. So the B is answer. If an involuntary contraction is seen during bladder filling, irrespective of the amplitude. Is it right? I think what I had in my knowledge was that it should be at least 10, more than 10 centimeters to tell it is an involuntary contraction. But okay. Which statement is false with respect to the hypothesis of detrusor pathophysiology? Which is false. Afferent sensitization signifies an increased afferent firing rate in response to a standardized stimulus. The myogenic and integrative hypothesis requires abnormal propagation of excitation in the bladder wall. Synaptic reorganization in the spinal cord may contribute to neurogenic detrusor overactivity. Detrusor overactivity requires volitional control, and synergetic coordination of bladder and outlet are determined at the brainstem and midbrain level. Which one is false? Yes, Saurabh? B. Okay, Saurabh also doesn't know. My God. D. So detrusor overactivity requires volitional control. That is false, definitely. All right, cannot have a volitional control. That is true. So with this, we come to the end to this session on today. Nimesh, do we have anybody?
No, sir. Two persons with without rename.
Without
is
name. So if I again asking the experts if they have joined us, please let us know. Otherwise, we will close this session.
Sir, good morning. Sir, Pawan this side, sir.
Okay, Pawan, good. So you don't have a name on your iPhone, so
Yes, sir.
so please go ahead. So Dr. Pawan. So we all know Dr. Pawan Vasudeva is the head of the department at Safdarjung Hospital. He was one of the members of the guidelines for overactive bladder, and he has a tremendous work done in overactive bladder, urodynamics, and female urology. So we welcome you, Dr. Pawan, to our teaching class. Thanks for joining us today. Please give your comments.
Thank you, sir. So sorry I was not there at the earlier part, but I think three things are important. Am I audible?
Yes, you are.
Okay. So I think three things are important when we are looking at overactive bladder, which sometimes we tend to miss. One is voiding diary is essential. You should not be treating a patient with overactive bladder without having a diary.
Yes.
Second, till the time you're treating conservatively, you may not look at the obstructive segment, but if you're planning to intervene in a patient who has overactive bladder, you must have their PVRUs and uroflowmetries measured. Okay. Even though the international guidelines do not ask for a uroflowmetry before intervention in overactive bladder, but it has been seen that patients with primarily obstructive problems can present with primarily irritative symptoms. Yes. So before you intervene, I mean, if you're giving drugs, till there it is all right. But if you're intervening, you must rule out an obstructive component. And third, now there is emerging evidence that antimuscarinics, earlier it was only about cognition, which was reversible. Now there is emerging evidence that antimuscarinics are also associated with long-term dementia, which is different from the temporary, memory loss or temporary cognition issues. So that is an emerging area which you will need to be aware before you counsel your patients about what drug you're giving.
Yes. Yeah. Thank you, Dr. Pawan, for joining us and making those very important remarks.
I just saw it. Yes, sir.
Yeah. Thank you. So he made three important remarks. One is voiding diary. Yes, very important in all these patients of lower urinary tract symptoms, particularly if overactive bladder and BPS and all these patients, overactive, this voiding diary plays a very important role. So never forget to ask the patient to have a voiding diary for about 2 to 3 days at least. And secondly, he told about there's all those tests like uroflowmetry, urodynamics are very important when we do some kind of invasive procedures. So if we have to start a patient on conservative therapy or pharmacotherapy, we may not do all these tests. We may straight away start with conservative therapies. And the third remark was about antimuscarinic. Yes, as I said, as I also mentioned about that, don't take very lightly these antimuscarinics for a very long term, particularly when these patients are old age patients. So there is an emerging evidence that it can cause dementia in many of these patients. So even if you have to put these patients on antimuscarinics, then we have to choose those antimuscarinics very wisely. Derifenacin and trospium hydrochloride probably are safer than other antimuscarinics in these patients. We need to start with beta-3 agonist, and then, if necessary, we may have to add. Right, Dr. Pavan, would you like to add something?
No, sir. Thank you.
Thank you. Thank you very much, Dr. Pavan. And we look forward for a urodynamic course with you.
Yes, sir.
Just as I was telling you, just try to contact Dr. Sujata, and so that we can fix up a date for the urodynamic. Yes. Thank you. Thank you once again for joining us. And I thank all the faculty members and residents for joining us today. Have a good day. Thank you.
Thank you, sir.